Like my favorite thing in the world to teach is bone. I see. I didn't even tell the other group this because obviously I like you better. Even though I sent them the outline, I outlined this chapter some years ago that I'll be using. So a lot of this stuff it gives you the opportunity with some of these outlines. It's the last one I have for a bit to be able to listen, and because I'm going to go over the same stuff. Okay? To be able to listen and maybe with some new insight, everything about fractures and bone healing and remodeling and different diseases that affect it. It's not as long as you think. I would guesstimate we have this early next week. This will probably be done, this particular chapter. So, I mean, that's there. So it affords you the opportunity to listen. What I loaded this morning on your Blackboard here, I just sent you. Uh, I loaded because the your textbook, the Welsh Hull textbook, I was using that for this lecture that I sent to everybody during when I was away for Friday out of town. Uh, and I kind of went over this, and it's good in some ways. I'm good, and I just sent you because again it's too big. The other textbook sequence that I think the illustrations are a little better that I'm going to use today, and that is this. This one is called 6A. We're going to start in roughly the same area, and some of it's going to reiterate things I would have. And we got through all this because I was trying to make it sort of lean in that regard, so you can understand what's going on. And I'll start right around this neck of the woods and go from there. Because we covered this a little bit. That's there. So that's where we're kind of heading. And so you'll see these on. If you want to open them, or just follow along with me for now, and get a chance to give a. And that's the other thing. Pet peeve number 2. Everybody listened like crazy to those review recordings. There's a reason I record these and take them to YouTube so you can listen. If you have a YouTube channel, which for whatever reason I do, not that I'm trying to monetize it, you see how many times people listen to your review. Not a lot of you did in all the classes. It doesn't tell you who it was. But when I do a recording and only 9 people have listened to it, and it's an hour lecture, that's on you. No, that's the reason they're there. Whatever I'm presenting in class, the best time to reinforce that in your mind, tonight, tomorrow. I realize you're busy. That's the idea. That's why pro golfers practice after the round to correct what's wrong. That's what professionals do. And many of you, you're going into professions. And it's like I said, nobody screwed up worse than I did in the first years of college. Can you imagine me with just being this far above probation after 2.5 years? Party. I'm blaming my ex-girlfriend. Do you know when she dumped me, the high school girlfriend? I got my birthday. That's low. That's low. I got my doctorate, and they put it in the local paper with a neat picture. All of a sudden, what is my son? Hopefully, doesn't want anything. In the local paper, receives doctorate, blah blah blah. I was already almost engaged to my first wife, and then I see her. This gal's very distinctive handwriting, and the mail slide came to the bottom. And it was the old "Let's get back together" letter. What are you doing? I'm in D.C. I'm working at the Smithsonian. Blah 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 blah. Hey, never responded. Remember, what goes around comes around. On with the show. Okay, this is bone. Bone has this miraculous blood supply. I presented it to you earlier. Our principal focus today is the long bone, to understand the relationship between cortical bone and cancellous bone. Think of a tube of aluminum. Think of something, maybe you're putting up a tent or putting up an awning or something like that. It's hollow, but the thicker the outside, that's cortical or compact bone. It just so happens it's not completely hollow on the inside because you're going to have what's called cancellous or spongy bone. So our focus point and the way you learn about bones and how they work and how they heal is study the long bone. Even though, as I sure you gleaned from lab, there's lots of other ones. The other one's short, irregular, and flat, like this. Let me get where my cursor is. Making me look bad here. Oh, heavens. Thank you. Short, irregular, and flat. Basically, the outer, this what we call compact or cortical bone, very thin comparatively. And by and large, they have a lot of what's called cancellous or spongy bone. It's a little bit different, and typically these are bone where you're doing as adults, and effectively all of us in this class have reached this stage, where most of the blood formation is going on there. Because that's the interior bone, even though it's a different system, and the bone marrow lining it is what we call hematopoietic tissue. You'll see that name. That's how it's pronounced. We look at it much more closely in AP2. Is where blood formation occurs. Most of yours has been replaced by fatty tissue in the long bones. It's not fat storage. It can be converted in terms of anemia or an emergency back into what's called red bone marrow for blood to be effectively for blood cells to be manufactured. So you'll see that the way it looks like this doesn't really have a true marrow cavity, but there's a lot of blood formation going in. This is what cancellous or trabecular bone looks like. These little plates, it's like a honeycomb. There's a ton of surface area. That's the magic. This would be like the bones in your skull. Very, very much so. Flat bones, as you can see up here, is probably parietal bone that they're reflecting. It's there. Our focus is on this, the long bone, because it's really understanding how bone makes itself, repairs itself, how bone grows, and reshapes itself. That's the understanding of bone. And I'm going to try to I don't want to make it like I'm doing in my advanced class. They're having a test on this today. So the shaft is called the diaphysis. It's got its own blood supply. It's really significant. That's a really important part. Surgically, you'll see in a second. We always learn where not to cut because you don't want to interrupt. If you interrupt blood supply to bone, it dies. Bone's got a great blood supply. That's what it relies on to heal. As long as you put bone in close proximity to one another and hold it from moving, it's going to heal. As long as the blood supply is intact. The ends are called epiphyses. The shaft is called the diaphysis. Okay, and the epiphyses, whatever you want to call them, head and base, top and bottom, proximal and distal, doesn't matter. Okay, they're a little bit different. They're more like cancellous bone. They have a thin rim of cortical bone, have cancellous bone in them. And indeed, in the upper portion of your humerus and in your femur, we have red bone marrow because there's a certain amount of blood formation that comes from there. That's it as an adult. Other than flat bones, the big areas where you have bone marrow that we access for bone marrow transplants or evaluations or to donate to somebody else, typically sternum and the iliac crest, which I know you had your bones practical, that upper portion. There's not a lot covering those. There's skin and there's some soft tissue and fatty tissue. Other than that, pretty easy access. And you sort of punch a little hole in it and suck out the stuff or put in the stuff, depending on what's necessary. It's also an important test that you might hear about in AP2 about diagnosing anemia and leukemias. You got to do what's called a bone marrow aspiration, because that's sort of the secret to finding out all of those types of things that are there. And you'll see all of these things, and we're going to look at it. What's interesting, so here is the humerus, just for instance, a classic long bone, probably the second longest bone in your body after of your longest bone, certainly in the upper extremity, counting tibia and fibula, but the femur is the longest and strongest. And here you can see the thickness of the cortical bone, and that's what makes them. We look at that. Lower extremity bones are thicker in the cortex as you're weight bearing. Upper extremity not as thick, but the more you use them. If you're right-handed, there's more on the right side. If you're left-handed, there's more on the left side. As many of you are choosing to be in professions, hopefully in the future, you're going to be standing all the time. Trust me, if you're working on a clinical floor, you're standing. Don't have, thank goodness you don't have to wear those old nurse's shoes. Oh, they were heavy and uncomfortable. Now everybody you can wear tennis shoes, sneakers, wherever you call them. They were uncomfortable. So nevertheless, that's where you understand the stressors that are on it. So the more weight bearing, the more stress that's upon it. That's there. This is kind of what it looks like. That thin, remember, they're made from a cartilage shell. all the long bones, effectively nearly all the parts of the connectors, the shoulder, what we call appendicular bone, has to do with appendages, the hip and shoulder assembly, all the long bones in the upper and lower extremity, all the bones for that matter, come from a cartilaginous shell. We call it enchondral or endochondral. In cartilage, chondral, we make bone. Enchondral or endochondral ossification. You'll see that when we talk about this on Wednesday. I've just spent a very, very brief amount of time on that on Wednesday, just to know where it comes from. All the cartilage is hyaline cartilage. What's left when blood here invades bone, it's got a fancy name, it's called the nutrient foramen. What it does is it basically kills the cartilage. They're very, very similar. It starts fibrous. You remember connective tissue, fibroblasts, chondroblasts, and osteoblasts. They're really cells that flip-flop. They can change from one another magically. So we start laying down fibrous tissue, then those fibroblasts, because they have that capability, because they're kind of variations from a stem cell line. Then you become chondroblasts. They make cartilage. All the cartilage is hyaline cartilage that the bone comes from. Cartilage is basically destroyed by blood. When someone bleeds into a joint, they get a thing called post-traumatic arthritis. Doesn't matter whether they're going to feel it now or 50 years from now, there's going to be arthritic deterioration. Because what's left of that cartilage when it's replaced by bone, and bones that move, is the ends. So that's called the articular cartilage. Articular means where bones come together. Just like the skeleton that are in there are called articulated skeleton because they're wired together. So you can see the relationship on bone. This one is a mature bone because it's got fat in there. It's called yellow, doesn't matter. Not a big deal to us. This, you get a better look. Here's what and the cartilage is really important. I'm not going to re-ask you any of those things you did in lab. The prominent is a greater trochanter, lesser, whatever. Yeah, I saw the practical. So you must have had a very difficult night after that. See, not that I would have gone home, and if I was a drinker, which I'm not. My wife and I didn't drink after taking care of those two little bandits where my son and daughter were away overnight. Then we're not drinkers. It's been a long time since the two of us, with a total of 8 kids together, have done that thing. Voila. This is what it looks like. Generous blood supply. Ton. Cartilage. A little bit of compact bone when you get near the epiphyses. And a whole bunch of blood supply. And a whole bunch of these nooks and crannies for bone. Okay? The most important part, I'll go forward to go backwards, is this. It's called the periosteum. Periosteum is a sheath that surrounds bone. They have one, it's called perichondrium when it's cartilage. It's a dense bit of fibrous material that's lined delicately on the inside with all those make new bone cells. That's where, when you break a bone, that's where it heals from. The vast, vast majority of the cells that come in and repair a fracture site come from there. You have similar cells that you'll see shortly called endosteum. Okay, there's an endosteum lining. They come from there. They may help a little bit sealing the interior of a broken bone. When you break a bone, all the pain comes from this because there's very few nerve fibers, that sensory nerve fibers in bone, but there's a ton there. And that's lifted up and blood fills under it and pulls it away from the bone. It hurts like crazy. It is so important that we incise it, delicately pull it apart, and sew it together once we finish working on the bone. I mean, I operated on bones for 25 years. So preserving the periosteum when you could is extraordinarily important. And a lot of times it was the basis of problems. When we saw patients with problems, the periosteum had not been preserved. So it's a really important bit of tissue. So here, glistening white, double layer, thickened fibers on the outside, all these new bone cells that we'll talk about on the inside. Okay, we call the osteogenic layer. It just means the osteoprogenitor is a fancy name for the bone stem cell. So all the bone stem cells, all the real bone cells, save one, kind of come from that. And they have fibers that sew that periosteum, called perforating fibers, anchoring tendons and ligaments. Tendons and ligaments attached to bone. It's magic how strong it is. I will show you in a second. These are these perforating fibers. They have a fancy name. They're called Sharpey's fibers. Capital S, proper name, capital SHARPEY''S. Example. This is the case that I did in what is now PPG Paints Arena, where Pens play. It used to be a hospital, and they basically put out the hospital from Old St. Francis and built the arena on top of it. An orthopedic surgeon friend of mine and I had a gal who was born with a you know, with the member in the foot, the navicular bone was in two pieces. The big, powerful tendon that keeps your arch up is called the posterior tibial. To reconstruct her arch, which was only damaged on one side, we had to remove the piece of the bone that was the tendon was attached to and reinsert the tendon into the remaining bone. It wasn't very, in the old days, they used to drill holes and sew it. To mimic how strong the body is, we had to use something called a MyTac. It's how the same device you would use to insert an Achilles tendon that had torn away from the calcaneus. We drilled a hole in the bone. We inserted this stem of this polypropylene. We use high density polypropylene because the body ignores it when it's inside. We stuck it in. It was like a twisty piece on like the cap of it, sort of like a mushroom cap. And it would come out with like 3 fish hooks that were like grappling hooks. If you know what they are, we pull them to anchor them in the bone. Coming out of the cap end were 2 like laces. Imagine, and we would lace them to the tendon the way you might lace up a pair of hockey boots or figure skating boots. And then that was what he and I did over about 40 minutes to be able to mimic how strong the body is for attaching, to mimic tendon and ligament attachments, to give you an idea how hard it is to deal with that. So it was a very good, successful procedure. She healed well. She was about 16, probably 30 years ago. I don't have any follow-up. Just to kind of give you a clue about bone. So what we're going to see, and then that was from this particular slide, anchoring points for that. The endosteum, delicate, covers those neat little nooks and crannies. Yeah, it does contain some of the cells. Not a big factor in healing or remodeling bone. Again, none of you have the original bone you were born with. Your bones have been replaced probably twice in totality. So that humerus, femur, it's not the same one. It's not like mine's just still there. No, they're constantly being replaced. Constantly. Maybe a little less frequently as you get older. You have blood supplies. That was the nutrient foramen. You got to be very careful. Blood supply to the ends, the epiphyses, separate. They are, and when bone loses its blood supply, it will die. You remember the femur. The femur, if you look at the head of the femur, there's a little indentation here. I don't know whether Dr. Robbins made a big deal of it. It's called the fovea capitis femoris, the little opening in the head of the femur. That's reinterpreting the Latin. There is a piece, that's where the blood vessel comes in to nourish that big head with all the cartilage that you saw about it. Best 2-sport athlete most of us have ever seen, a guy named Bo Jackson, was MVP of the All-Star game in football and in baseball. Give you an idea. And innocuously, he was hit going out of bounds in just the right area to dislocate his hip enough that it separated that blood supply. He never effectively played again. He underwent a process thing called, orthopedists are familiar with, called avascular necrosis. The head basically died, flattened out, became arthritic, and at an early age, probably in his mid-40s, had a hip replacement. I mean, his post-playing career is very, very successful. A very bright guy from Auburn. Great 2-sport athlete. Just to give you an idea of how important these things are. And I have a ton of these. I did about 20% of my practice was sports medicine. About 60% of it was diabetics. So I had a nice well-rounded, mostly older, but I had a lot of young athletes particularly sports that I was interested in, with running, with a lot of skaters, because all my kids were hockey players and skaters. Never again. That's why I will not go in an ice rink unless forced. One of my grandkids is skating. So here's what it looks like. This is the neat part. Here are the fibers. Here are the blood supply. This is what we're going to look at. Okay. Red bone marrow, talked about all of those things. Yeah, it's replaced by yellow, and you can read this. Convert to red if you become anemic. You did all this in lab. Don't want to do it. Don't want to do it. Blah, blah. Bone cells. Bone cells are fairly straightforward. Okay. These just means these are stem type cells. Think of this as in that periosteum. Effectively, fiber cells, cartilage cells, all of them, when they're busy, we call them blast. So, and they all can convert to one another. So the fibroblast and chondroblast effectively, when that cartilaginous shell is invaded by bone, we begin to see a conversion. But if bone is damaged, broken, or remodeling, and again, it's remodeling constantly, depending on forces and weight. You see me, I wrote it over there. It's called Wolff's Law. We'll visit it again. Your bone adapts to the position it's in. If something terrible happened to somebody and they became paraplegic and wheelchair confined, their bones would change the way the joints were, because they couldn't effectively straighten their legs. If someone has a stroke and they're contracted like that, they're arthritic. Okay, those bones and the joints adapt to the forces that are on them. It's just the way it works. When I worked on a lot of arthritic people and tried to deal with that, we would operate and reset the bones, take a chunk out, reposition the cartilage if it was tilted one way or the other, straighten it out, secure it there, pin it, screw it, wire it, whatever. So the osteoblasts make bone. What they basically make is collagen, a ton, and a particular protein that attracts calcium. They call calcium binding proteins. That's the ground substance. The collagen are the fibers together. That's the matrix. What gives it the hardness is when the collagen is attracted, and when the calcium salts. And you'll see the calcium salts are mostly calcium phosphate. Okay, there's some magnesium phosphate. There's some probably calcium carbonate. Calcium phosphate predominates, and the crystals form, as you'll see subsequently, and it's on both of the PowerPoint sequences, called hydroxyapatite. I'm not going to bother to spell it. You'll see it, but it is on the test forthcoming. Crystals, just the name, so understand what the crystals are. And so what happens as the bone is active, doing whatever it's doing, it's forming all these things. As the calcium begins to deposit, the signals change and indicate, okay, we've got enough bone deposition. And at that point, the cells get surrounded by this matrix, hardens. And they're then, once they basically are just functioning normally, building a little, breaking down a little, they're what we call osteocytes. Again, they can flip-flop from one of these stages. And the same thing would be true of a fibrocyte, if you saw connective tissue, or a chondrocyte in actual cartilage, let's say an infant or a young adult. Let's say a teenager or a pre-teenager rather. Cyte just means it's in that stage. Bone lining cells, it's unclear what they do. And the ones that are in there that really are all about, they're really not a true bone cell. The osteoclasts are a cluster of white blood cells, basically like macrophages. They call them multinuclear. So it's really a giant cell with a bunch of cells that are contained within it that are there to absorb bone. We have to pull out calcium. They become very active, or they're quiet unless we have to remodel bone, like take away bone that's been damaged or fractured. And understand, bone is a giant bank for calcium. It's all about it. We do a whole little unit on the hormonal controls with parathyroid hormone and vitamin D, and understanding what are the triggers and why they're there, and calcium, getting to understand the importance of calcium, which is just so vital. They're called osteoclasts. When something does clast, the suffix means to destroy or break apart. So the osteogenic cells, a stem type cell, vast majority in the periosteum. Osteoblasts, the osteoid is this unmineralized stuff. collagen and calcium binding proteins. The only, again, the only fiber you're going to see in bone, collagen, collagen. Those Sharpie's fibers, collagen. 90% of the bone protein. And so and the cell look doesn't make a difference. I'm never going to show you that. So, but it's really sort of undefined. It's just busy making stuff. When they mature, we see with cartilage and bone a thing called a lacuna. It looks like a little cavity. It was like, oh, they're surrounded by an empty space. It's an optical illusion of the microscope. What happens is it doesn't mineralize in that area. There's still material in there, but what happens as it begins to firm up around it causes these cells to have these tentacle-like. Imagine firming up here and it's sort of squeezing that osteoblast, and these sort of little tentacle-like projections allow the cells to remain in contact or send signals to one another. Whether they're, and I'm doing it this way for a reason, because it's sort of like side to side, like you and I, like maybe we were in kindergarten, we could touch that finger and you touch that finger, et cetera, that type of thing. And it's either chemical signals or electrical signals that are there. This is what the osteoclast looks like. Multiple cells. It's active all the time. When they're inappropriately active, we think that could be a reason for osteoporosis. You don't have to worry about osteoporosis. You live long enough, you're going to get it. Okay? Let's be clear. We have a whole unit on that also. So going back and looking at the sites, they maintain it. They deal with everything. They communicate with one another. If you had ever had a cast on or had a broken bone and they put an immobilizer on it for a long period of time and you finally got out of it, you could take an x-ray. The x-ray wouldn't look, it would look like you'd lost calcium. Young, healthy people, a couple of weeks, right back. Muscles get back. It's a process called atrophy of disuse. In older folks, much worse. Because then it begins to atrophy because they're not nearly as active or as busy. That's why my wife is constantly yelling at me, and she's absolutely right. Get off my posterior. Gym, etc., like that. But I'm tired from work. It doesn't work. And the lining cells, not sure what they do. That's why I don't deal with them. Fancy name, these have what they call ruffled border, surface area to break down the bone. Down the road, we'll talk about the enzymes that are there. We look for these enzymes to try to evaluate certain bone diseases. I'll probably talk about that ever so briefly. And this is really, to me, the focal point of the last 15 minutes or so we have, are the layers of bone. Effectively, compact bone, it's like a series of pillars. And they're all made up of those long channels of bone. And we have it's almost like we surround them with more bone material, and in between them, almost like glue, holding them together. And it's tremendously strong. One, you could snap together, just like braiding. Very, very difficult. It becomes very, very strong. It's called each one of those individuals are called an osteon. The fancy name, Haversian or Haversham, I've seen both of those. And you're going to see up and down blood supply, they have canals. The central canal goes up and down for each one. And then you have little canals that go from the outside perpendicular. Okay, you're going to see they're called Volkmann's canals or transverse canals. You're going to see those in a second. And those little channels that kind of go side to side with the cells talking to each other are called canaliculi. Again, teeny tiny canals, like little threads. So here they are. Compact, little cylinder, tiny weight-bearing pillars. Rings of bone. They look like little tree trunks. You probably saw that microscopically in lab. You'll see the same kind of illustration. They're layers of collagen fibers, and the way they're arranged tells you everything you want to know. I mean, each one of these is proteins and binding. The fibers run. You want to make this counterclockwise, it's clockwise. The alternate, each ring has you the strength. You're going to see in between them, they have little bonds that can break. They're called sacrificial bonds. Sometimes you'll run, you just all of a sudden catch an ankle, or you twist something, miss a step. You wonder, boy, I hope I didn't break anything, and you didn't. It's because those little bonds will give way, and as soon as the stressor is removed, they'll reform. So they'll sacrifice themselves, albeit temporarily, so the bone will hold. Unfortunately, it's two-edged. A lot of times you're better off breaking a bone than having a really bad sprain. Like a high ankle sprain, simple ankle sprain, a couple of weeks. High ankle sprain, 6, 8, 10 weeks, maybe surgery. So here's the central canal, big blood supply. Reversion canal is another name. These transverse ones that go toward the middle, you'll see the illustration, Volkmann's canals, perforating canals, tangential canals, all those names, and they're going at right angles into the interior. So there's multiple pathways for blood supply, and they all have nerves in them. Again, not a lot of sensory nerves, but nerves and blood vessels kind of play together to make sure things heal. The lacunae are those, if you want to call them cavities, that to me, cavities implies there's nothing in there. And I think that's more of an optical illusion from staining. And the little canaliculi run circumferentially. And then little gap junctions and send messages and communicate nutrients and waste. The layers that surround it are called circumferential lamellae. Lamellae means layers. The ones that are in between, interstitial lamellae. You see it in the illustration. And again, all of that plays a role in maintaining the integrity of the bone under force. We do a lot of stuff. We jump in and out of things. We do athletic activities. I mean, there's so many things, and you wonder why the bone doesn't give way. I've been very fortunate. I never had a bone. Go figure. I don't think my wife has either. And we'd like to think, even at our ages, we're fairly active. Here's what it looks like. So here you can see each concentric layer, the fibers running differently that are there. So that's what I mean. It's like a series of like tree trunks. This is the central canal going up and down. Each one of those osteons has one. Here are the perforating or Volkmann's canals going into effectively the bone marrow or cancellous bone area. This is all cancellous bone. It's all draped in blood forming, particularly when you're young. Here's what it looks like with a real micrograph. You can see the blood vessels that are there. This is the classic microscopic view of long bone. Each one of those little areas is a lacuna. We assume a cell's in there. And each of these little threads, particularly the ones going side to side, are the communicating channels. And you can see them a little better here. You have, here are the lacunae, and at least they've represented it with something being in there. Principally the cell and maybe some surrounding soft tissue. And then you can see these little thread-like areas, the little canaliculi, front and back, side to side, all forming in those layers. That's a really good illustration. So the circumferential layers underneath the exterior of the bone, holding all the pillars in place, and the interstitial layers, making sure the pillars stay secure to one another. And so this wonderful arrangement just gives this immense amount of strength. How much strength does it give it? Here we go. Okay. The spongy bone is a little bit different. It's organized based on stress. We look at those to determine if someone's getting a stress fracture or a stress point. We look at those to evaluate for osteoporosis. They draw the analogy of like cables on a suspension bridge. They don't have osteons, but there's a pattern that forms that are there. And they're showing you that same illustration. So a lot of areas, the construction is very elaborate. And then the organic and inorganic components, you have, we call it osteoid, that's unmineralized. About 1/3 of the weight is this. That's the binding proteins and the collagen fibers. The mineral salts, the inorganic components, are what make up about 2/3. I'll probably show you that hydroxyapatite name. This is really telling. If you want, you can say it in one phrase, one little bullet point. 2 components in the right proportions. Bone is half as strong as steel. Take a steel made into a humerus. Take a humerus. push down. How when you compress the steel, think of how much pressure you have to have. The bone will even upstand half of that pressure. Twisting it, they're equal. Equal. Here's the osteoid itself. They're talking about the sacrificial bonds that are there, high tensile strength. So they resist the stretch and break and dissipate the energy to prevent fractures. And then they reform. Again, a lot of times the good things in the body are a two-edged sword. I talk about them all the time. We have them in respiratory, we have them in circulation, we have them in kidney. We have so many backup systems that it gives us a false sense of security. And that's something that, as people get older, that really rears its ugly head. I'm much more experienced with gerontology, older people, and the things that go on. Here's that name to remember, hydroxyapatite, 65%, 2/3 roughly of the weight of the bone. All these calcium phosphate crystals with some other mineral content. The big one to remember, calcium phosphate. Of course, we're familiar with it. Skeletal remains. I'm sure Dr. Robbins talked to you about ways that we can look at the femur and the pelvis and determine male or female. You can determine the growth plates if they're present. Under X-ray will show cartilage, and that'll tell you whether it's, let's say, a child or a small adult. All of those things, even which growth plates are there. You'll be in children. If it's children's bone, will tell you which child, what the age of the child is. And with these cold cases or forensic remains, the age gets very, very interesting. So that's where, it's a whole subspecialty in pathology. And that's everything for today. I'm going to go into how the bones grow and elongate. I'm going to go into the hormonal stuff and what controls the calcium. We have a very big unit on fractures that I have a lot to share with you. And then we go into osteoporosis. And that's really what all you have to do for both. So thank you.